few twisted cases. Dr. Huma Ashraf, our senior postgraduate resident, will represent the cases. Discussants including Dr. Ahad Qayyum, Dr. Arsalan Khalid, and Dr. Adil Manzoor will deliver their perspective on the topic. Dr.
Slight change in.
Okay. Well.
Assalamu alaikum. Post-transplant cases for histopathology. Case number 1. A 63-year-old male, ESRD due to unknown etiology, underwent live-related renal transplant on 14th September 2023. Donor was his blood group compatible wife with 6 out of 8 mismatches. Luminex and flow cross match was negative. He was induced with ATG and methylprednisolone and started on maintenance of MMF, tacrolimus, and prednisolone. His post-transplant best creatinine was 2.1 milligram per deciliter achieved on second post-op day, which then started ascending slowly to 7.7 milligram per deciliter. Urine output was good during all that time. His urine and blood culture showed growth of E. coli, so he was administered culture-driven antibiotics. Renal biopsy was performed on 22nd of September 23 due to static creatinine at 7 milligram per deciliter despite resolution of infection. And repeat biopsy was also performed on 5th October to look for any evidence of rejection.
Okay. First of all, thank you very much for inviting me here, and it's always an honor to come here and present cases. So this is the guy, 63-year-old, and this is it has actually 2 biopsies. This is the first biopsy, which is taken in, I think, in September. So I don't have pointer. I point out things. This HNE stain, and in the mic move करने mic Thank you very much. So we have biopsy, HNE stain, and in the center, this is the glomerulus. Then come closer. Okay, so in the transplant biopsy, we always see 3 things. Number 1, is there any rejection? Number 2, recurrence of disease, or is there any CNA toxicity? So these are the 3 things which we have to see. So there are so many things, but I'll concentrating more on the biopsy. So there is no inflammation in the glomeruli, so no glomerulitis is present, and in the tubules, all the tubules, there is no inflammation. These are the tubules. There is no inflammation. There is some injuries present in these tubules because there is loss of fresh water. There is some sloughing off of epithelial cells. So these are the features which are of injury. So in the next slide, we can see that these are the tubules. They are more injured. They are more dilated, and there is some cause, but I was thinking this is hemorrhagic cause because this is more eosinophilic, and there are some dilated vessels. Maybe the history of hypertension is also present since the guy is 63 years old. So I haven't seen any sign of rejection in this biopsy. So this is the PS stain. In the PS stain, I haven't seen any sign of tubulitis. There is no glomerulitis and no dilatation of microvessels or peritubal capillaritis. So again, there is injury in the tubules, and these are the normal tubules, and these are the injured tubules. There is loss of fresh water here, and some epithelial cells are also missing. Again, there are some dilated tubules with some cause, but these are look like more as the hemorrhagic cause. There is some foci of inflammation. Inflammation is of mixed kind, some lymphocytes, some rare eosinophils, but there are some patches only. So in the trichrome, it has some definitely fibrosis, but it's in the milder stage. C4D, which is definitely required for, not definitely, but we usually do for in order to see antibody mediated rejection is present or not, but C4D is negative. These are the flush areas which are present in the tubule, but the vessels are negative. So the second biopsy was done in October. And now, as a comparison, you can see that they are more dilated tubule. Okay, and injury, the level of injury has increased. So there are more casts. Some casts they are look like hemorrhagic casts, and these are the casts which are different than these casts. On the high bar, we can see that the casts are surrounded by some inflammatory cells. There are few cracks here. Again, there are few cracks in the center, and these casts are surrounded by some inflammatory cells. Low power as well. Now you can see more and more inflammatory cells are coming, and these are the cells which are usually they are macrophages, and sometimes we can see neutrophils as well. Again, on the PS stain, now the cracks are more evident. Okay, large tubules, more cracks, which is, I think, in the transplant biopsy, this may be the first or second case. Here you can see that there are some more inflammatory cells with giant cell formation. So these are the casts which are basically surrounded by inflammatory cells. Again, PS stain, same features, but no glomeruli. There is no glomerulitis or no transplant glomerulopathy. Some changes in the vessels, but there is no vasculitis. There are only maybe the age-related features of the vascular arteriosclerosis. Trichrome, almost same, mild fibrosis is present. So then finally it was diagnosis. The one thing, there is no feature of rejection. Second thing, there is severe acute tubular injury with the luminal cast, and mild fibrosis and marked mucoid intimal fibroblastic or arterial narrowing. So with these, with these kind of luminal casts, the first differential diagnosis is this may be the cast nephropathy. But we can suggest that this may be cast nephropathy. But the rest of the things, I think these are the guys which are more knowledgeable than me, and I can now referring my case to these guys. For I think this is cast nephropathy with this morphological features, and there is no evidence of any rejection.
Right. So I'll now give a brief. In between the time of the two biopsies was 8 to 9 days. The patient was not resolving. The creatinine was thinking that, but ATN which was not being resolved. But I cannot sit on it with 7 to 8 creatinine. Then I did the second biopsy. Then Sir was saying, hey, what is the story? I said there's no previous history of myeloma. I just want to highlight one thing. When I came from Saudi Arabia having such a massive myeloma exposure, I was doing for patients with unknown kidney etiology in 50%. In every patient, all the myeloma workup markers, including a low-dose CT, serum free light and kappa lambda ratio, serum SPEP with immunofixation, UPEP with urine immunofixation, and all these tests were being done. But actually in all these first two transplants with the yield was 0. So I gave up doing this all 4 tests, which I was doing routinely. And in this patient, I just realized maybe this is also a kidney failure of unknown etiology. So he gave me a clue on the phone. So SPEP with immunofixation, UPEP with urine immunofixation, serum free light chain and kappa lambda ratio. And we did a low dose CT, which we do for myeloma patients here. And this is the result. So we found a monoclonal band, and see the lambda. Can you show me the serum free light chains? Look at this lambda, at 0.01. And then I went back that I have previously once in my life missed a patient of myeloma in my life. So I said this is the second case I met. But when I went back to the history, there was virtually no history. And the low dose CT was not showing any lytic lesions. So then, because starting of the BMT service now, hematology is very much accessible to us. And we then, the next morning, the bone marrow was done, which was showing 80% plasma cells, 80% plasma cells. And patient was virtually having no symptoms. Then with this is the report now of a bone marrow, 65% of the cellularity. His fish cytogenetics have been sent, and flow cytometry we have also done, and we have started him on Cybo-D regimen. Patient feels good, but creatinine is very, very slowly improving. So just want to see, just want to tell us that sometimes when you drop investigation because it has got a very low yield, the case comes back.
Very nice case report. I've never seen such a case post-transplant in my center, but recently, because I trained many nephrologists from Georgia, I went to Tbilisi and we had a case review series, and they have had 2 cases as yours, totally the same. And the thing was that one patient never recovered from ATN, and the other recovered, well, not too badly.
Right. So I think while you were presenting the case, I think that is what we were discussing, that maybe he's got myeloma, which I found it hard to believe that we would have missed this. But it is very, very common. So it's more of a comment than anything else. Anybody, even during our training days, this is what was told to us. If the patient has unexplained renal failure, greater than 50 years of age, always rule out myeloma. But, considering that we don't, as you said, that the yield is low, we always sort of say that, oh, the calcium's okay. I can't think. He doesn't have none of those things. So let's just, and if I was doing this transplant, probably I would have done the exactly same thing that what you did. Yeah, nothing's there. Yeah. So, yeah, SPEP probably, as during our training days, if greater than 50, 55 and unexplained, should be done. But is it done? I doubt that it's done. Wrong. Thank you. Excellent case. Yeah. Teaching point. It's an excellent teaching point. Unexplained renal failure, slightly advanced age, SPEP needs to be done. Yes.
Our hematologist says that if kidney failure recovers, then they may consolidate it with the autologous stem cell transplant after the patient is in remission. So 2 cycles of Cybo-D, and then if he goes into remission, will be consolidated with autologous stem cell transplant.
More of a comment, because we see this thing that patients who end up on dialysis because of myeloma, when you treat the myeloma, sometimes they get off dialysis. So, and not with only that transplantation. So do you think that, once we treat this myeloma, yeah. 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 Yeah.
Proceeding to case number 2. 26-year-old male with ESRD due to reflux nephropathy secondary to neurogenic bladder underwent live-related renal transplant on 21st September 2021 with mother as donor. His pre-transplant immunological workup showed no preformed DSAs. Flow cross-match was negative. He was induced with ATG and methylprednisolone and maintained on tacrolimus, Silcept, and prednisolone. He had uneventful post-transplant course for 2 years with nadir creatinine at 1.2 milligram per deciliter. In June 2023, he developed oliguria with vomiting over a period of 3 to 4 days. His creatinine uptrended to 8 milligram per deciliter. Pre-renal and post-renal AKI was ruled out. No de novo DSAs were reported. He was pulsed with methylprednisolone and renal biopsy was performed on 2nd July 2023. He was subsequently given 12 milligram per kg of ATG and TAC level maintained at 10. However, his creatinine became static at 5. He was then rebiopsied on 22nd August 2023.
I just want to tell you one that this guy, this young boy, was doing absolutely fine, and his tacrolimus was always been in the therapeutic range, 7 to 8, 7 round about that, and there was no any non-adherence or compliance was excellent, very educated, and this all came at a blue.
Okay, ji. So again, this guy has 2 biopsies. So this is the first biopsy on the HN staining. So there are these blue areas which show inflammation. Again, on the high power PS stain, these blue areas, these blue patches, these are the areas of inflammation. So this is the glomerulus, and there is no significant glomerulitis. So all the peripheral capillary loops, they are patent and there is no inflammation. And but definitely there is inflammation is there. Okay. In the PS stain, again there are inflammation and there is no there are some dilated peritubular capillaries, but no inflammatory cells are present here. Now, in this picture, we can see that these are the tubules which show inflammatory cells. Now the pointer is gone. Battery is down again within 5 minutes. Okay, the dilated tubules, and we can see that inflammatory is within the membrane at the basolateral position of cells. And again, there are few other tubules which show the same morphological features. So this is basically a criteria that we must have tubules, normal tubules or moderately atrophic tubules with the inflammation in the basement membrane at the basolateral position with the perinuclear halos. So it has definitely tubulitis. So we require at least 2 spots or 2 different areas in order to say that tubulitis is present or not. So in addition, there is inflammation in the interstitium, and inflammation overall, if we quantify inflammation, that was almost 25 to 30%. So not working, man.
My
So it was इसको हाँ okay ji. So inflammation is at least I2, and there are more than 10 inflammatory cells in one tubules. That means T3 is also present. Okay, so overall if we quantify, so there is no peritubular capillary dilatation, there is no inflammation. Again, there are different areas. You can see. Okay, and there are dilated peritubular capillaries and without any inflammation. C4D was negative. This is the C4D is negative. So this is definitely a T cell mediated rejection, which is acute and which is at least 1B, at least. So again, the second biopsy was done in August after almost 2 to 3 weeks.
Okay, and this was the second biopsy for a 26, and the patient was not resolving. Patient is 3 years post transplant, baseline creatinine 1.5, went up to 7. We gave some AT, it came back to 5. I was not satisfied. I said repeat a biopsy.
So one thing was missing. I actually cannot tell you with the projection. There are some plasma cell loss. Yes, this was the very
Important finding. The next biopsy, Mudassir told me that there is a lot of plasma. Then I told him that this boy is not going to recover. We have lost 2 grafts because of rejection. Both are in this in our presentation today. So he's the one who has lost a graft because of the late TC.
Okay, so this is the second biopsy. Again, there are areas of inflammation. All the blue areas, they are inflammation and dilated tubules. So again, yeah, of course, there is definitely edema. There is edema. There is no fibrosis. Fibrosis is mild, but there is edema, and the tubules, they are now increasing their distances between them. Again, there are inflammatory cells within the tubules. Tubulitis. Again, and there is definitely some atrophic tubule. We cannot count those tubules which are the size is less than 25% of the normal. So we cannot count those tubules. So there is again at least T3 and I2 and significant plasma cells. Significant means that definitely there are more than 10% of plasma cells were present. So almost the morphological feature was the same in the both biopsies. So there was no reduction in the inflammation, there is no reduction in the plasma cells, and there is no ABMR. C4D is negative. So this is again acute T cell mediated rejection 1B with moderate interstitial nephritis with plasma cells. And there was edema and the tubular atrophy was present in here. Yeah, arteries were included, but there was no vasculitis. Only there was mild thickness in the wall, but there was no arteritis.
So after that, we gave him about 2 to 3 milligram per kg more. So totally received 12, as Homa said. And then we gave up, and then patient is now on dialysis. So the important learning message for myself was that, as we have seen a lot of patients now, that the TCMR, early TCMR phenotype and the late TCMR phenotype are both separate and different entities. And the late TCMR, because of the fibrosis long term, it does not respond to the therapy very well, and the return of the renal functions and the disappearing of the lymphocytes.
Was the graft enlarged of size at the time of rejection? Okay, because I came across with such cases a long time ago in 2 settings. Those patients were, because just like it was inundated with IL-2 and interferon gamma to explain the edema plus metastasis. Settings where patients were treated with alpha interferon for Hep C virus, and when they were having acute T cell mediated rejection. It was this pattern. It occurred just in a few days, and they had a huge increase in their size. The second were highly sensitized patients who had no DSA, but were involved to develop acute TCMR as such. Yeah. So it's amazing. But I came across with such case. No, no.
So, yeah, because I mean, you're saying that it is late T cell.
Late TCMR
Yeah,
phenotype is totally a different ball game.
First biopsy, I don't think it was that late because the
No, no,
question was
no,
yeah,
no, no,
but you
I-
give him
in-
enough ATG and you gave him solomedrol.
Yes. What I was trying to tell early TCMR and late TCMR,
Yeah.
early TCMR occurring very early post-transplant.
Yeah.
And
Oh, so
late
that standpoint,
after
yes.
1 year after
Yeah,
transplant.
that's
Because
fine.
of the scarring, the fibrosis, that are both different phenotypes.
I thought you were
The
talking about
resolving
acute.
of the renal function, the resolving of the histopathology is not so much in late TCMR.
We also see quite large number of plasma cell rejection, but those usually occur in the setting of non-compliant.
Non-adherence.
Non-adherence.
Not adherence.
The number
And
one.
always in plasma cell rich rejection, you still have to rule out antibody mediated rejection, the DSA and all the things.
And one thing is, the setting of clinical trials on the cancer patients were given IL-2 therapy, IL-2 to fight or to upregulate the T cells against the tumor cells. They find out to have acute AKI, and those patients who have had kidney biopsy have the same features. Plasma cells, diffuse edema, which is the hallmark of cytokine, IL-2 or gamma, and T cells around. So it's a very peculiar rejection. So maybe because patient has had diarrhea, maybe he had before that subclinical TCMR,
Possible.
and because of diarrhea, maybe he was underexposed to the specific drug, and thereafter was boosting the T cells, but not in that.
And the other important point is that in these patients, you have to also rule out PTLD with these plasma cells.
We have treated some of these cases
With bortezomib.
bortezomib.
I've written that, but there's not a large data. I know this.
Did have diarrhea.
Yeah.
Was he exposed to a virus maybe which was immunomodulating? Because he's talking about it.
It's possible, but his CMV, PK, everything was done on the first. A norovirus, we don't have the PCR here. That's sent abroad. Multiplex. We have that multiplex. Stool biofire is not there still. Pneumonia panel is there. Biofire.
Because just to remind us that we have the cytokine storm, and this is the hallmark of inundation with cytokines. So you did the best, at the right time.
People ask one very important questions for the audience, because they said that for any person, is there any cumulative dose of ATG that should not be exposed in a lifetime? Any comment?
Well, what has been shown in the past is that the highest the amount of ATG given, the highest the risk of de novo PTLD or cancer in the long term. But that's it. You just have to be aware of this additional risk. That's
Because
it.
it was a young patient, I see
I know.
in the future second transplant. No more.
Yeah, you're right.
Okay. Anything from the audience?
So, is the B cell in any way incorporated within the BAF classification? Is plasma cells in any way, are they being talked about?
No, not yet.
So, what's the significance of plasma cells in a C cell mediated rejection and pathogenesis behind it?
Makes it more severe, and it is still included in T cell mediated category. It is not body mediated.
I mean, when you've got plasma cells in your kidney biopsy, it means that the kidney will not last so long, as far as I'm concerned. Every patient who has had plasma cells in the kidney biopsy has lost the kidney within the next months.
What's the reason for plasma cells? That's the question. Is there a reason?
I don't know. Well,
He knows that it will be treatment resistant. Whatever you do. I read this reports about proteasome inhibitor given for this plasma. But I don't know, Mubarak, in the world it is not published.
I don't know about treatment. I think it works. Yeah, in our setting, in fact, we have published it that Howard would have been better.
Yes, which one?
Plasma cell.
Plasma cells we can see on the morphology. Yeah, we can see very easily. If there is any doubt, we can do CD138 or CD38. We can do.
And kappa and lambda light chain immunohistochemistry can also.
For clonality.
clonality.
For clonality. No, not
नहीं,
at all.
नहीं.
Not at all. थोड़ा सा भी मेरे जैसा नहीं कुछ सेंसिबल हो ना हिस्टोपैथोलॉजिस्ट तो वो मिक्सअप नहीं करता. No, I haven't done. Kappa lambda is required whenever there is any question of clonality.
You wouldn't give it
So
still would.
there is no question of clonality in this case. If there is any plasma cell related disease, then we can do kappa lambda, because if they are pathological or they are present there, and I haven't done it. Yeah, sure. Okay. So this is the next case.
Case number 3, a 43-year-old female, CKD5 secondary to autosomal dominant polycystic kidney disease, underwent preemptive live-related renal transplant on 1st September 2023 with husband as blood group compatible donor. Her pre-transplant immunological workup included 7 out of 8 mismatches on A, B, and DR. Luminex was positive for class 1 and class 2 antibodies, and DSAs were detected against A with a mean MFI of 1041 and against B with mean MFI of 1634. Flow cross match was negative.
With ATG 6 milligram per kg body weight. Flow was completely quiet.
Okay. Okay, so this is the histopath of this lady.
She came to the ER with a creatinine of 6 with no symptoms on day 6 of transplant. We discharge the patient usually on day 4. So 2 days after the discharge, came to the clinic with from a normal renal function to creatinine to 6.
Okay, ji. So H&E stain in the biopsy, so we can see that there are lots of inflammation, which is acute cell neutrophils, and this is the one of the representative glomerulus, which shows fibrin thrombi. Here, this is also a thrombus. So again, on the high power, we can see that there are lots of acute cells which are present, and they are present in the peritibial capillaries. And this is one glomerulus which show that every area of gloom is full of thrombi with some neutrophils in the capillary loops. So there are vessels which also show the fibrin thrombi. Okay, on another area, another gloom which show almost the same morphological features, we can see and say these glomes as bloodless glomeruli, because the blood cannot pass through these glomes whenever the features of acute TMA are present. So this is the PS stain, and we can see that these are dilated capillary loops and with our massive thrombi present. And in the some areas, acute cells are present. Again, so silver stain, so there is no double contouring. We cannot see double contouring so early actually in the transplant biopsies. The trichrome stain, and in the trichrome we can see the thrombi, they are more pink in the trichrome. So these are the thrombi in the glomes, some in the vessels. So my first impression was this is TMA, of course. This is a TMA is a feature actually. TMA not a disease. Can be on account of acute CNA toxicity, can be acute ABMR, hyperacute ABMR, or some, there are so many causes, platelets, ADAMTS mutation. So, but in this context, so this is C4D. And you can see that the C4D is present in the every peritubal capillary. So these are tubules and these are the peritubal capillaries. SV40 is negative. And diagnosis. So my diagnosis with this C4D with massive thrombi in the glomeruli and inflammation, acute inflammation in the peritubal capillaries, this is a hyperacute type of ABMR.
Accelerated acute.
So,
Follow-up of the DSs, that all that preformed DSs. Please read now.
Okay.
on repeat DSAs were positive against A with MFI of 16,351 and against B with MFI of 6,068. Subsequently, she received 6 plasmapheresis sessions followed by administration of IVIG's rituximab with no recovery, and subsequently patient was initiated on dialysis.
So this is the second graft which we have lost because of the rejection. The first one was that boy, and the second one was this. So he received plasma steroid, along with that steroid, pulses, plasmapheresis, IVIG, rituximab, but we could not get any. It was such a severe anamnestic response of the rebound of the antibodies because of the exposure to the fetal paternal antigens. But we have not seen such a rebound. Our policy in PKLI is that if DSS is positive, flow is negative, we use only induction therapy with lymphocyte depleting agent 80 full dose 6 milligram per kg. If the patient is having a flow cross match positive, then we do desensitize these patients. As the same Khabar was telling, we use rituximab at day minus 30 or 23, like that's whatever the convenient, and then we do plasmapheresis depending upon the mean channel shift of the TCS or BCS, where such an aggressive approach as Khabar highlighted 7 sessions. For example, a B cell mean channel shift is like 130. I might be doing only 2 sessions of plasma. But flow negative, DSA positive, we give only induction capillary and keep tacrolimus level rock solid around 10 to 12, and cell sept and prednisone. But this is really a very devastating case for us. Some programs do some manipulations with these patients with the DSA negative also. DSA positive and flow negative, that they might give them IVIG or rituximab. But I think in our setup.
So this is a very demonstrative case and it's very sad for sure. In my center, for every woman who has low level of DSS with negative flow, either with deceased donors or living donors. So with living donors, it's very easy. We give rituximab twice, 1 month and 2 weeks before, with a negative flow but DSA positive. And when it comes with a deceased donor, if the flow cross-match is negative, having DSA on board, we just give rituximab as of day 2 because we cannot. Conversely, for deceased donor, if the flow is positive, the CTC is negative, we perform plasmapheresis before the transplantation and retux day 1. But it just reminds us that, in fact, this is the worst scenario. A husband donating to a wife, which is very sad for sure. But, you know, by definition, have our B cells, T cells who are committed against the husband HLA antigens, even though there are no DSA. And for me, it's a very, not risky, but at least they should be considered as very high risk in people transplants. And therefore, I would advocate, even though there are no DSAs around, I would advocate for giving rituximab just one shot before transplant, because by definition, she is sensitized against that, for sure. And it means also, relatively in France, eculizumab would have not changed the fate because it was so strong. So,
Right. So I definitely agree. Once on day 6 this has happened, I think we were on a slippery slope and the graft would have probably gone. So the only the difference, yeah, sorry.
Other than this scenario,
Yeah.
whatever anamnestic response, early AMR, we
Yeah.
have been able to reverse them completely.
So that is the most interesting point. That what I'm saying is that from a bookish point of view, this is precisely what we were doing. So 10, let's say there's 10 cases, the MFI 900, 600, and that is what you're getting, and we get away without rituximab. But this is but we have seen this,
In the morning, Haber has shown the big data.
but we have seen this too.
But the important learning point what Dr. Rostang and what I concluded from this case, that the woman,
Yeah.
woman husband,
Yeah.
woman offspring,
Yeah.
that is a separate ball game as compared to the every DSA is different.
So
Every DSA is different.
so rituximab, I gather we should make it a part of our protocol. The rituximab, it's
If
just a
there is a
rejection
husband
to wife.
you
Yeah.
that might require a desensitization, but how is it visible in our country?
A light one that wouldn't involve plasma exchange, that wouldn't involve IVIG, it would just involve rituximab, and that we can take that on board.
you know, I've got a very nice case, a very sad case. It was during the COVID pandemic, okay? And so it was a living-related transplant, husband to wife. And she had very low levels of DSA. It was 2 years during COVID, 2020. And I skipped rituximab because the flow was negative, okay? In fact, at the end of the day, she ended up, it was not as strong as that, but she ended up with acute ABMR, and thereafter she has received plasmapheresis rituximab. She ended up with chronic ABMR, and she lost the kidney 9 months later. And this is a single patient that escaped my protocol, in that constellation, husband to wife, and it was a catastrophe.
Strictly speaking, this should be severe acute ABMR, not hyperacute, because it has occurred beyond 24-hour time period. And secondly, there was also dense lymphocytic infiltrate in the interstitium. So, was there component of T cell
That was
concomitant?
actually not the lymphocyte. They are all neutrophils, but I cannot project them actually here in this. But they are, yeah, they are all neutrophils.
If there is a husband to wife, offspring to mother, if there is a low level DSA, rituximab should be administered. Huh? You can give 2 doses.
One dose might be enough, but at least 1 month before. If you want to deplete, there was a very nice study published in the New England Journal, I think, by Mark Peskovitz group he was working in Iowa City. So he was giving in sensitized patients rituximab at various dosing, 100 milligram, 200, 300, 500 milligram. And the day of transplant, they were assessing the number of B cells in the iliac lymph nodes, which are a surrogate marker for B cell depletion, not in the blood, it's pointless. And in fact, they showed very nicely that if you want to have a B cell depletion in your iliac lymph nodes, you need to give at least 400 milligram once to have this depletion. And it's what we want to achieve. And there was various timing, 1 month or 2 weeks or 10 days, I forgot. And the depletion was less if it was given 10 days as compared to 1 month before. This is the only work published so far as the timing and the dosing. At least it's 400 for American patients 400 milligrams, and 1 month it's better than 10 days. That's it.
Duration of action of rituximab is usually 3 weeks.
So
So at
can
least 3 weeks.
rituximab lead to false positive B cross match?
It will lead. It leads to us in our program. Always. That is the all. You can dissect that also. You do an auto cross match, it will be positive. That can be dissected also.
Thank you very much, sir. So I think so in the context of preform DSA, if we keep this male husband to wife model keep aside, if there's a preform DSA, irrespective of the fact that you are getting any movement on the floor or the CDC, so your induction arm, like at the time of the transplant, has nothing to do with the rebound, to prevent the rebound, like with the Simulec or the ATG. These are just the tools to prevent the ACRs. So I think so it's mandatory to do something to prevent the rebound. Abhi to allograft pura aaya hi nahi hai. The moment you will put in the kidney, so how are you gonna monitor? Are you have the fixed protocol to monitor the DSAs every 2 days, 4 days to check the rebound? Because the DSA was there at one chosen. So I think so there should be something like rituximab minus 30 days to prevent the rebound. Otherwise, no matter if you are using low dose or high dose ATG, it will not do anything to prevent the rebound.
Number one, for the B cells mobilization, anamnestic response, you're right to some extent. But for the antibody, you need in the germinal center the help of the TFH cells, the T follicular. Without the help of the T follicular cells, the protocol which I am telling, the class 1 DSA, other than the sensitized like the husband or the offspring, if you go into the river, all the class 1 DSAs go away.
Sir, I will not consider this an amnestic response because the DSA is already there, sir. It's there before the transplant. So amnestic to ये है कि DSA negative है, वो sensitized है, it rebounded.
ठीक है.
So I'm saying in this scenario, if you have already a DSA in the circulation, so it will be rebound, not an amnestic response.
Outside the wife or husband, or outside the offspring to mother,
Sir.
low levels DSA, other than a stronger lymphocyte depletion therapy, does not require any additional.
Well, it's hard to comment on like maybe Rosalind can. And
Well,
this,
it's difficult to comment. The way is, if you've got circulating DSA detectable the day of transplant, and she had very low levels, indeed, the increment of production will be very high because of the low immune response that is going around. But if you deplete your B cells beforehand in these situations, by rituximab 1 month or 3 weeks before, the likelihood of developing an anesthetic response with the B cell will be lower because you've got almost no B cells around in the lymph nodes, which is the key point. And so therefore, if it's the case, because you have given rituximab, it will save you of using high amounts of ATG, for example. Or...
So this consensus has slightly changed now. So consensus is that you might want to consider rituximab, even if it's not women getting it from a mother getting it from the husband or from the offspring. Yes, am I right in saying that if you've got a low level DSA? So essentially, what we're trying to say is that low level DSAs matter as well, and we might want to individualize care. I doubt that we'll be able to come up with a consensus based on 4 people sitting here and correcting.
but it's the cross matches are run in the labs. In vivo and vitro, there's a difference. So there would be a rebound.
I totally get what you're saying.
The whole allograft.
But Naveed, if you look at the other way around, I'm sure that you've transplanted patients with low level DSAs and nothing happened without rituximab. And but did anything happen? So that's what I'm saying. Yeah.
So last year I presented in this conference. He was a relative of mine, high risk category में mother to son इस तरह से नहीं वो pass. There was a DSA. These were tertiary hospital. They did nothing. That was the second graph. There was no movement on the floor and the CDs. On the 6th day post-op with acute abdomen, जो जिससे present करते हैं MR और वो सारा कुछ there was suspicion fungal है and the biopsy was 100% conclusive for acute accelerated AMR.
It can happen. It's not a matter.
सर तो अगर हम ये टूल यूज कर रहे हैं और हमने 1 लाख का टेस्ट करवा लिया है और हम ATG भी 10 मिलीग्राम तक देंगे तो why not to give ऐसे patient में?
मैं आपको इसमें तो चलो आप ऑफस्प्रिंग की मदद तो बनती है,
Sir.
लेकिन what the world does, majority what they low level TSA low level is desensitizing these type of things outside the offspring. If you look at Stanley Jordan and all these banks, who are experts at Bob Montgomery, who's done thousands of desensitization and all this.
If there are situating low-level DSS with negative flow, we are always giving rituximab 1 month away. This is the last one.
Yeah, I mean, programs may be. DQ are the most resistant to treatment. No, DP and C will not move the flow crossmatch because the antigen expression nahi hai. DQ even 8000 will not move the flow crossmatch because its expression on the endothelium is also not. Yes.
Okay. So now, just starting the last case.
But if you really reviewed it now, if you ask any who is that person he was doing the most, the surgeon, the ABO incompatible and HLA incompatible. What's his name? He's a Muslim. A Muslim. He does not do desensitization for all these patients. And in USA also. Every center may vary in the practice patterns, but we have to decide what is suitable for our country. SIUT has just shown that, and their paper now is this one, the Haver paper, has been published in Clinical Transplantation 3 months ago. हाँ आप पूछे. Which one? Because he was having high class 1, class 2 Luminex was positive now. Screen positive. No, it was not on the. I'll tell you, whenever we have a cutoff of 1000 on the Luminex, we are doing SAP. And I just told you that the beads expressivity of the antigen. Was there a SAP ka result to देखो? Bead expression on the Luminex is different from the on the SAP. हाँ, देखना. This is based on the risk stratification. One patient, I'll tell you, if somebody has no DSA, the patient will receive 4.5 milligram per kg. Or if it's an elderly patient, he will receive simulacrum. If there is a DSA, all patients will receive lymphocyte depletion. HLA class 1 and class 2 screening phenotype beads will not show you whether there is a DSA. Only when you will dissect these cases above a certain threshold that you will come up with the DSA. All the risk stratification of the patient changes from low risk to high risk. He goes into the high risk. The patient has gone into the high risk based on this 2 DSA.
That problem comes up that you have to be comfortable with whatever lab you're using also. It can't be any lab saying that I can do it. It has to be a highly specialized lab, which is the problem which we face. Yeah. That is also lab issue.
Indeed, if you trust your lab, and I think it's very trustable, 1,000, 1,600 is significant, but not enough to shift your progress match.
In the
conversely, in other labs, the cutoff might be 500 or 3,000, depends on the sensitivity.
Last case now.
Yes.
38-year-old male with ESRD labeled due to diabetic kidney disease, never biopsied, underwent live-related renal transplant on 4th April 2019. Donor was blood group compatible brother. Pre-transplant immunological workup revealed no preformed DSAs. Flow cross-match was negative. He received ATG at 5 milligram per kg and methylprednisolone and was maintained on MMF, tacrolimus, and prednisolone. He had uneventful post-transplant course for 2.5 years with nadir creatinine at 1.5 milligram per deciliter. During post-transplant follow-up in December 2022, his creatinine uptrended to 2.5 milligram per deciliter with 7 gram per day proteinuria. His graft biopsy was performed on 28 December. He was subsequently pulsed with methylprednisolone and received 8 plex sessions with albumin along with 1 dose of rituximab, followed by prednisolone at 1 mg per kg, and MMF was increased to 1.5 gram BID. His creatinine downtrended to 2.2. Later on, during post-transplant follow-up, MMF was switched to cyclophosphamide due to persistent drug-induced diarrhea. His creatinine is now static at 2.2 milligram per deciliter.
Okay, ji. So, 38-year-old guy and general transplant biopsy. So this is adequate biopsy with more than 10 glomeruli. There are 2 vessels. This is one of the glomerulus, and this is the HNE stain. There is a significant patch of inflammation. Okay, on high power, we can see that the glomes again is dying. Again dying. Okay. No problem. Okay, so gloom is enlarged in size, and there is some increase in the mesangial cellularity. There is some So there is some increase in the size of the gloom, and with some lobulated architecture, we can see that these are the lobules of gloom. Overall size is increased, and this is PS stain. In the PS, we can see that there is no significant tubulitis here, but the main pathological disease is present in the gloom. With large size, increased mesangial cellularity, there is lobulated architecture, and membranes are thick, and there are few neutrophils are also present. So here we can see that the thick membranes with some double contouring, I'll show you in the silver stain, but overall it's so we have many differential I'll discuss later. So here, so we have 2 contours in the peripheral capillary loop. Here as well, you can see these 2 contours. There are inflammatory cells in the gloom. So with this morphology, and this guy has the pre-transplant disease was MPGN. So this can be a feature of MPGN, of course, but this can be a feature of transplant glomerulopathy. But usually in the transplant glomerulopathy, we don't see more mesangial cellularity. Size can be increased. There are definitely double contouring. There is glomerulitis. So there are overlapping features, but in the silver stain, you can see here. In the trichrome, there are only few patches of these blue areas which are showing fibrosis, but C4D was positive. Okay.
C4D was negative.
C4D was just patchy positive, just patchy positive. Yeah. So the pre-transplant disease was MPGN, and in the IF was C3 was positive, IgG was positive, and C1q was focal positive. Okay, and there are only few patches of C4D was also present. This is the CD3 which is present in the mature T cells. SV40 was negative. So I gave actually differential diagnosis in this disease. Yeah, the one thing pre-transplant disease was MPGN. I gave this is maybe a immune complex type of MPGN. Because some of the overlapping features were present in the form of double contouring,
transplant glomerulopathy, inflammation in the loops, and there was some patches area of C4D was also positive. So I favor it as MPGN on account of the features and the previous disease, but gave a differential that this may be a chronic form of antibody mediated rejection or chronic ABMR. So this is it. I think.
But sir, he did not have a pre-transplant biopsy. He was labeled as diabetic kidney disease.
So
Immunofluorescence was showing the picture of an immune complex MPG, and I remember the case very well.
okay.
You gave the diagnosis of immune complex MPG.
Yeah.
And pre-transplant biopsy, and very important point, also learning point in these patients. Many of these patients who have been labeled as diabetic kidney disease in Pakistan and Goa have mostly have some other cause of their kidney failure. And again, referring to my talk in the recurrent GN, you have to still keep in mind and screening in the post-transplant period for proteinuria and the recurrence of the disease. And I think this is the 100% the same thing. He had ESRD probably due to an immune complex MPGN, the ICG and the type 1 of the new classification, and he has the rebound of this disease. And we gave this patient plasmapheresis. CellCept was increased to 1.5. Rituximab we gave 2 doses. And because, as you know, in the native kidney, the data about the treatment of immune complex MPGN, if you rule out all the secondary causes, the infections, the autoimmunes, everything, the idiopathic MPGN, the treatment is all over the place. If you have rapidly progressive disease, you give IV cyclophosphamide along with high dose steroids. And if C3 eculizumab has not so much role in the immune complex. So we gave him a lot of plasmapheresis. We gave him ACE inhibitors. We gave him SGLT inhibitors. CellCept was increased, 2 doses of rituximab again. He did not tolerate CellCept 1.5. Then I stopped CellCept and changed him to oral cyclophosphamide. And in about how much, 2 years now, we have been able to stabilize this graft. Its proteinuria is still 2 grams, but the graft is
I think
going
we've
on.
done this biopsy in the last June, I think. Almost 1.5.
There was no monoclonal gammopathy.
No monoclonal gammopathy, no DSA.
Okay.
8 weeks only. He's back to the CellCept dose which he tolerates, which is 500.
Most likely recurrence of MPGN.
And the learning point again is this: the diabetic kidney disease. There is a large studies done on patients with diabetic kidney disease that 1/3 of these diseases are because of non-diabetic kidney disease. But I think that this, which study I am quoting, may be subject to a publication bias, because we are only doing biopsies in diabetics in selected cases, which we are thinking as any other cause, non-diabetic renal disease causing anything. So these may be some publication biases in these patients because you are selecting and dissecting this patient.
Thank you.
Okay, thank you very much for tolerating 1 hour. They are.
Where is time? You're here? You're here?
Yeah, I'm here. I would like to have tea.
Okay.
Dr. Sunil Kumar is a profound professor of infectious diseases at Sindh Institute of Urology and Transplantation. Now he'll talk regarding fungal infections in transplantation.
Thank you, Dr. Adil, for invitation. जब सुबह से हम लोग सुन रहे हैं, nephrologists are giving big guns rocket launchers and mortar guns, everything they are firing, to hoga kya? Your immune system will be down, your defense system will be down. This means you don't have defense with you, or then chunti can become hathi. Normal, even normal commensals, normal part of our body can hit you and hit you hard actually. So today we are going to see how fungal infections are actually hitting us. So we will talk only about invasive fungal infections because there are some localized disease also. So we will not go into detail about regarding that actually. So bit to start with, we classify fungus actually on the basis of how they look like. So we broadly classify in 3 types. One is yeast cells because they are small rounded like structures. Some hyphae, these are ribbon like structures, and dimorphic means maybe both actually. This dimorphic usually cause cutaneous lesions, tenias. We will not go into detail of these. We will see what are relevant regarding our transplants. So in yeast, the most important is candida. All the patients transplant develops oral candidiasis. You must be familiar. So we will discuss candida, invasive candida. Another is cryptococcus, which usually causes cryptococcal meningitis. PCP or pneumocystis or PJP, it was to be start with, it was not fungus, but lately it has been now classified as a fungus. In hyphae, we have 2 very broad categories which can cause clinical infection. One is Aspergillus and one is Mycor actually. So we will discuss 3 of these: Aspergillus, PJP, and Candida. This cryptococcus is relatively simple. It causes just cryptococcal meningitis, not much of a diagnostic problem. And Mycor is usually not really a post-renal transplant problem, more of a pre-renal transplant problem because classical risk factors are diabetes and acidosis. So usually we see these kinds of patients in pre-transplant. Post-transplant incidence is very rare. That's why we are not going to discuss. We are just going to discuss these 3. So in invasive fungal infections, there is different literature report different data actually, and its incidence usually in the range of 2 to 8%. In US data, the most common was Cryptococcus and Aspergillus, followed by also Candidiasis. And there is a very large group which also causes, but that's actually a very large number of pathogens causes. That's why we are not going to discuss in detail. Luckily, although we usually classify just fungus as a fungus, but it's actually depends upon different names which we just learned. So there is data from Pakistan in different populations, different incidents are there. But if you look at the data published from Pakistan, this 777 is just Aspergillus and 4 cryptococcal meningitis. We don't much have data regarding different fungals from Pakistan, and this is journal actually. Most of the cases on the extreme right, 3,636 cases that rates per 1 lakh population is of vulvovaginal candidiasis, which is again a localized candidiasis. So what I tried to make 3 cases, and we will try to learn through cases how can we suspect infection in these. So the first case is 40-year-old female who undergone live donor liver transplant 3 weeks back, had complicated post-operative course due to biliary leaks, so received meropenem for more than 2 weeks and had ICU stay too. And now she develops new fevers and tachycardia. No central line, abdominal scan, there was no collection at all. Blood culture grew yeast cells, which is candida actually. So in this patient, what are the risk factors for candidiasis actually? One is transplant. Second is complicated post-operative infections course for which she received broad spectrum antibiotics. We will discuss these risk factors in detail in subsequent slides. So when we actually think about infections in transplant, there are some things needs to be keep in mind. That diagnosis is very challenging because there is a wide range of pathogen which can cause similar presentation. And signs and symptoms are often masked by immune system because usually this is immune system which gives you sign symptoms. When you have actually masked the immune system, you have altered the immune system. This means patient may not present with the classical signs of fevers and other symptoms. And at the same time, we have to keep that graft rejection, duct toxicity, even malignancy can present in similar ways. Actually, we need to keep these three also in mind when we are dealing with post-operative course of a post-transplant course of a patient. So to actually have differential diagnosis in mind, it has been classified. Okay, you should have your transplant in your mind, and up to 4 weeks, there could be nosocomial infections, which usually hospital-acquired infections, depending upon whatever risk factor you got. If you have central line, there could be central line infections. If patient has got catheter in situ, different drains in situ, these can cause infections. So nosocomial infections. Second is donor-derived infections. Usually, candida don't cause donor-derived infections, but it's one of those nosocomial infections. So for the first 4 weeks, your differential could be these related to this actually. And in Pakistan, there are more gram negatives causing this actually. There's one candida which can come within 4 weeks of transplant. Our patient was just 3 weeks back, patient was transplanted. So candida in transplant usually occurs within first 3 months of transplant, and it's classically a nosocomial infection, which could be bloodstream infection secondary to central line. There could be intra-abdominal corrections or different complex surgery, more common in the liver transplant than kidney transplant. And it could be UTI presenting as candidemia or invasive candidiasis. Those risk factors usually in general population like age, more than 50 years, broad spectrum antibiotic, use of central venous catheter, parenteral nutrition, prolonged neutropenia, prolonged ICU stay, diabetes, renal replacement therapy. These are actually a general population. These are risk factors for our patients also, because most of these risk factors may be present in our immediate post-transplant period. But there is this choledocogenostomy done in liver transplant, that's actually a risk factor for candidiasis in patients with liver transplant. In liver transplant, previous antibiotic use, bacterial infections, same post-renal transplant, reoperation, if they have reoperated, they have reopened this patient because of some complications, and CMV infections are more risk of invasive candidiasis in liver transplant patients. How we diagnose them? Usually we diagnose when we isolate a candida from a sterile site. But the problem is the overall yield of blood culture is just 40 to 70%. So we may not have positive blood culture in every patient in which we are suspecting candidemia. So we do have non-culture based techniques available in which we have this beta D glucan assay available with us. But the problem is that sensitivity and specificity of this is 70%, not a very good test, but that's what we got. We do have PCRs, but currently these are not available in Pakistan. And so we need to decide on this candida score, in which the classical risk factor we have identified previously, we need to decide on these actually. We don't have any explained or microorganism justification of our presentation, then we should think about candida, and it's usually immediate post-transplant. Something about role of BDG. This is a local published data from Pakistan from 2015 to 2019, in which they have saw different candida species can predict about candidemia. So this is non-candida auris is usually 236 actually. So this is BDG. The normal value of BDG is 80. Ideally, it should be double of that 80 to be significant. This means because there are lots of false positives for beta D glucan. So if it's more than 160, then you can think about that. And except Candida auris, this is local data from Pakistan, the mean value was 236 actually. But one good thing about BDG is that you can pick them even before candidemia. Two species, the topmost is Candida albicans. So see, this is the day of candida. This is day 0 of candidemia on day blood culture. So you do have a high beta D glucan even before candidemia. This means you can pick that up actually, except Candida auris. In other species, you can pick them before developing of candidemia. Candida species actually, this is very important. Okay, we should not have just Candida in mind. And this is a Spanish data in which they have seen there is a significant shift from this Candida albicans, which was 31.2% to down to 21%. And there are non-albicans species which are coming up as a predominant species which cause post-invasive candidiasis. And that is very important when we are choosing our antifungals actually, because different antifungals have different susceptibility to different species. For example, fluconazole, it do not covers Candida glabrata and Candida cruzi, which may be a common pathogen species in your setup actually. Everybody should know their own species, which is a prevalent species in your setup. For example, at my institute, we have more Candida lucitini as a cause because it's usually related to central line, and 90% of our patients with renal failure, when we start dialysis, they are on central line. So our common species is actually Candida lucitini. So this means your choice of antifungals will be decided on basis of this, because this Candida lucitini, it may be resistant to amphotericin B. If you have parasitosis common in your setup, it has actually high MICs to echinocandins. So that's why the species level is very important for you to know, to decide about your own empirical antifungal when you are suspecting candidemia. So treatment, international guidelines say that echinocandins is in hemodynamically unstable and previous azole exposure, or alternative is liposomal amphotericin B. But again, for example, in my institute, we don't start these both of them, because we have the first topmost is lucitini, followed by second is parasitolosis. So these two may not work for me. So that's why we start fluconazole as the first choice, because we have more of Candida tropicalis. And now we have antifungal susceptibility testing also available in Pakistan. Targeted treatment can be started once we know the species. And transition from echinocandins to fluconazole can be done if your patient is stable enough. Echinocandins is currently available in Pakistan now. One of them, caspofungin, is available. So you can decide starting that depending upon that. Lipo currently not available in Pakistan through a proper channel. It's through dubious way, so we should doubt whether it will work or not. And supply chain is always actually not with us. Do species predict mortality? Yes, the Candida species can predict mortality in a large cohort from a transplant data. If you have Candida tropicalis and parasitolosis, that's actually a blue one and green one. There are more chances of that. So your species also can predict your clinical failure and mortality once you pick them up. So do involve your microbiology lab and ask them up to species level they should identify, rather than giving this is just Candida species. In liver transplant, there are guidelines to recommend in high-risk patients who have more than 2 risk factors, like prolonged or repeat operation, retransplantation, renal failure, high transfusion requirement, that is more than 40 units of blood, choledochogenostomy, and candida colonization in perioperative period. Out of these, if 2 risk factors are present, they should be put on fluconazole prophylaxis for at least 1 month. Well, this is the time at which there is high risk for candidiasis in patients with liver transplant. In kidney, we do not give prophylaxis. We usually treat depending upon whenever they actually come to us. Moving to case B, second case. This is 35-year-old female who received renal transplant 4 months back, presented with low-grade fever and shortness of breath. Immunosuppression was tacrolimus, microfluid mofetil, and ditocortil. But her Septron, trimethoprim, sulfamethol were held after 1 month of usage due to pancytopenia, and it was never restarted actually. So after 4 months, after 3 months of stoppage of trimethoprim, she came to present it to us with a history of fever and shortness of breath. So important is 4 months back, and trimethoprim was held actually. Her CT was done, which shows ground glass opacities in perihilar region. Bronch was done, in which the culture was negative. The galactomannan is 0.5, to which lab report is positive. Keep this in mind. We will discuss in our case, next case. But her PCP by immunofluorescence was positive, along with PCP PCR and SARS-CoV, because that classically after that 2019 pandemic, it can present similar as PJP. It was positive, and the beta glucan in our case was 500 actually in our case. So back to our timeline. Our patient came from From 4 weeks up to 6 months, this is a period at which most of the opportunistic infections occur actually. This is a period that there may be reactivation of CMV, there may be listeria, toxoplasmosis, PCP, because this is a period, if everything going on, this is where the period of most intense immunosuppression. So up to 6 months, the risk of these infections remain high actually. And in our patients, we have stopped trimethoprim sulfamethoxazole because of pancytopenia. She developed PJP after 4 months of transplant. So in pneumocystis, actually, incidence is again variable depending upon what kind of transplant you are doing. This is the above data is when we were not offering trimethoprim. So highest incidence is in heart transplant. The kidney has got 0.6 to 14%. But with effective prophylaxis, now it's down to 1 to 2%. But if you look at the graph, when these patients develop PJP, that again, we will just talk about that kidney transplant. They usually develop within 1 year of transplant. After 1 year, it's rare to have PJP in routine practice. The classical risk factors for PJP have been through multivariate analysis recently done about more than 4 lakh solid organ transplant recipients was allograft rejection, lymphopenia, CMV, BK related disease, and when you are using bortezomib as a induction therapy when you are using it as a anti-rejection drug with 3.92, and even rituximab with 3.02. So these are the risk factors which have been identified as a high risk for development of EJP in recent analysis. Signs symptoms are actually very non-specific. Patient may have fever, dyspnea, cough, chest pain. These can be actually any presentation. One characteristic point which can be is this last one is hypoxemia. It occurs usually in more than 80%, and characteristically this is exertional hypoxia. What we usually do, if we are suspecting, we ask patient to have a 6-minute walk test. They actually tend to desaturate when they walk actually. So others may or may not be. How we investigate actually? Chest radiograph usually not helpful. It may or it may not be. We usually pick them and CT scan in which there are characteristic bilateral diffuse ground wall opacity with interstitial infiltrates. Similar to COVID, but it's usually in this, there is a more central, and COVID, it was more peripheral. That's actually different. But in any case, you need to rule out SARS-CoV-2 in every patient with ground glass opacity and interstitial infiltrates. We can go for direct demonstration of organisms, like in that, actually we will discuss in next slide. But LDH is usually elevated. Most of the studies say that LDH is usually more than 300 in most of the series. We can go for PCR if it's available to your setup, but the problem is that it do not differentiate between colonization and active infection. There are some data in which say 5,000 copies can be utilized as a differentiating point, but actually there's not much data to support that. Actually, we do see in our setup PCP PCR of 2,000 copies, but when we are not suspecting PJP, we have done BROC, we have alternative diagnosis, patient responded because our reporting time of PJP is usually 4 days. So immunofluorescence negative, so we don't treat them actually, but there's no strong cutoff. Like at least it has got very good negative predictive value, close to 100%. If it's negative, it usually rules out. We will also discuss algorithm in subsequent slides. Beta-glucan actually it's releases from cell wall of a cyst actually. It's usually elevated, but we need to, because beta-glucan is a pan-fungal marker, so it's usually elevated in other fungals also. So we may not be help you. But in our setup, we usually see in patients with beta-glucan, it's usually 500, which we don't see in other kinds of, even in Candida, we don't see usually 500. So when we see 500, there are more chances of PJP with appropriate clinical scenario. The yield of this immunofluorescence PJP PCR depending upon what sample you are sending. If you are sending bronchoalveolar lavage, the yield may be 80%. If you have done transbronchial biopsy, again the yield is very good. But if you are just sending sputum, the yield is very poor, even if it's not recommended to test for that. at least have an induced sputum in which the yield is 40%. The best is to counsel your pulmonologist to have a bronch done, early bronch, or at least mini bal done. If they are able to do that, if you have a tech who can do mini bal, that can send for, because that has good negative predictive value. Not a good, no good sample, nothing that. We can go for immunofluorescence and PCR, but again, the PCR we have discussed, it may be difficult at what level it is. So, so to diagnose, we can have actually a combination of everything actually. So in appropriate scenario of dry cough, hypoxemia, dyspneic patients with compatible radiology, you should do beta-D-glucan. If the beta-D-glucan is negative and immunofluorescence stain is also negative. If you have low to moderate suspicion, patient don't receive any high rejection, anti-rejection treatment in last 6 months, you should search for alternative. But if your suspicion is very high, your patient is in intense immunosuppression period, you should go for ask your pulmo to do a bronch with BAL actually, because even in that the yield is good. So if the PCR is positive, you treat it. If the PCR is negative, ideally we should go for transbronchial biopsy, because the yield of standard is still the standard, gold standard is transbronchial biopsy to rule out PJP. If its PCR is positive, treat. If it's negative, then you can rule out actually. Otherwise, most of the cases we are plus minus, we usually treat them. But if your beta-D-glucan is positive, no stains obtainable, and your suspicion is very high, you should treat presumptively, because there are patients who are NIV. Pulmonologists usually don't agree to do bronch in these patients. If the patient is on NIV, he may desaturate. In that, appropriate clinical risk factors in your mind, appropriate clinical presentation, bit guidance from beta-D-glucan, because it has a good negative predictive value, start treating them. Treatment is trimethoprim sulfamethoxazole, usually in the dose of 15 milligram per kilogram. Other options actually not available in Pakistan currently. None of the etovaquone. We in some cases we do try permaquine and clindamycin, but the problem is that it is only recommended for moderate disease. It's not for severe disease actually. The trials in which they have tried permaquine and clindamycin, they all show a very high mortality with this regime. There are certain indications for steroids. When your patient is hypoxemic, you ideally should give steroids, ideally within 72 hours of trimethoprim sulfamethoxazole, ideally before that. And the dose could be 40 to 60 milligram depending in adults, and there should be tapering over 14 to 21 days. So there is data coming from oncology practices in which particularly heme-onco, they are doing low-dose subtran, and they have documented that if you do, the dose is 10 milligram and high dose is 17, which we usually do conventionally, they have seen similar ICU admission, similar patients on mechanical ventilation, but less adverse events. So this has never been tried in solid organ transplant. I haven't got across anyone using 10 milligram, but we can try, because I think with our immunosuppression protocol, we have usually azathioprine in our regime. We see lots of bone marrow suppression after starting trimethoprim after just 5-6 days actually. So rather than stopping, we can just lower the dose actually. This actually a thought which can be done in patients in which we are suspecting that. Third case, 35-year-old male who underwent transplant 5 years back, presented to outpatient clinic with history of fever for 1 month and cough for 15 days. But he received anti-thymocyte globulin 3 months back due to cell-mediated rejection. Prior to rejection episode, patient was on PRAD, cyclosporin, and azathioprine. Current immunosuppression is PRAD, tacrolimus, and MMF. 5 years back transplant. This means the risk of infection should be very low in these patients. And systemic examination unremarkable. Baseline labs were normal, but there was jump in creatinine from 1.9 to 2.5. This is chest X-ray. कुछ लग रहा है chest X-ray में? None? कुछ नहीं? ये इसी पेशेंट का CT scan है. That's why I always think आपको, if you are suspecting something with respiratory, go for CT scan. Don't believe on chest X-ray. early CT scan is going. Look at the lung in this patient and look at this upper lobe, right upper lobe, which actually we, even after looking at this, we go back to X-ray and we are unable to find anything in that chest X-ray, even knowing the pathology. So in this patient, we did a bronch in which there was a pus cell numerous. Culture was no pathogen. PJP was immunofluorescence and PCR was negative. The BAL galactomannan was 0.8 actually, and serum galactomannan was 0.7 actually in this. But there was no growth of aspergillus or anything in these patients. So this is actually real scenarios which we usually encounter in our clinical practice. These galactomannans. So back to our chart of suspecting pathogens. तो यहाँ तो हम क्रॉस कर चुके थे ना, 12 मंथ से भी आगे चले गए थे. यहाँ क्या हुआ था? What happens in this patient actually? Dr. Adil has given ATG. What ATG or anti-rejection treatment? It resets your immune system. Your risk of infections go back to zero actually. The risk of every infections, like we described for 6 months, it risk again increases. Your risk of CMV, risk of PJP, risk of every infection increases whenever you're going to treat, regardless of time have been spent actually. And this, as an ID physician, we need to remember that when patient has received high immunosuppression, because high immunosuppression means my risk of infection again. So in this patient, although my patient is 5 years back transplant, but because received within 3 months received ATG, this patient developed aspergillosis. So again, the risk of invasive aspergillosis is actually very documented up to 0.7 to 4% in renal transplants. It's more common in lung transplant, heart transplant. In liver also the data after immediate, the risk is very low actually. In kidneys, it has been documented that the median time was around 400 days. Classical risk factors which have been identified in particularly renal transplants is underlying lung disease, diabetic nephropathy, receiving post-transplant hemodialysis, surgical reintervention, any post-transplant bacterial infections, respiratory tract infection, CMV, acute graft rejection. But the living donor has got, which we usually do, living donor has got a protective effect. That's why we in our practice we usually don't see that much high incidence of 4% in our renal transplant recipients, because we are usually doing live related transplant in which the odds ratio is 0.65. This means there's a less risk as compared to Western world. But CMV do increases the risk of invasive aspergillosis. If we see meta-analysis in forest trial, the odds ratio is around 3.31. More risk of developing aspergillosis once patient develops CMV. CMV being notorious virus, cause all kinds of increased risk of infection because of immunomodulation. In our cohort, we usually see a pulmonary aspergillosis in 89% cases, but we do have disseminated aspergillosis in brain also, and we have 1-2 cases of even cutaneous aspergillosis because of probably direct inoculation from bandage or some trauma. Diagnosis, actually, this is very challenging because culture is not always possible, and the presence of aspergillus in clinical samples, particularly respiratory one, may not suggestive of an invasive disease actually. So culture method is not going to help us much in patients with aspergillosis. Radiology, all different kinds of radiology have been described, in which ranging from cavitating disease, having crescent sign, all different kinds of signs have been described for aspergillosis. So again, the radiology is not going to help much in when we are suspecting differential diagnosis. So this galactomannan, the problem again of this, there are lots of false positives and false negatives with galactomannan. It's a fungal biomarker. It releases from that. For kidney transplant, actually, if we follow the cutoff 0.5, the specificity is just 58% in patients with renal transplant. There are some recommended. They are recommending when you are doing serum galactomannan. As our institute, we also follow that 2 readings of 0.7. Or if we have done bronch and then the BAL galactomannan is more than 1 actually, The laboratory cutoff is 0.5 actually. That's where we have a fight with our transplant team also, where they say that they are reporting positive, but the sensitivity is very poor when you follow that 0.5 cutoff in BAL. Actually, most of the guidelines recommend 1 in BAL, 2 readings of 0.7 in patients with of serum galactomannan, but serum galactomannan can be negative. So it's more of mixture of both. That's why I've shown in my previous case with PGP, the galactomannan was positive with 0.5, but in this case, I have make it simpler of 0.8 in BAL, but there is 0.7 in serum. That's why we can make a diagnosis of invasive aspergillosis, because culture is not going to help us. That's beta-glucan, that can produce, but actually it's a non-specific marker. There is a role of coming aspergillus PCR. The literature is coming up that the sensitivity may be good, but again, the environment in which we live, where the lots of constructions going on, lots of humidity effects, I don't know this aspergillus PCR, how did it perform in our labs actually. We do have aspergillus PCR currently at SIUT. We are doing piloting in few patients along with other suspicion marker. Then we may find in our scenarios, in our setup, its value. So again, if we are suspecting we have solid organ transplant recipient with clinical symptoms, radiology favoring, for proven we need histopathology evidence, or we have direct microscopic examination of biopsy with tissue damage or growth of aspergillus from a sterile site. For example, we have aspirated brain abscess. Otherwise, the usually what we are following, culture positive, along with positive galactomannan in serum 0.5 or 0.7, BAL1, along with aspergillus PCR, this could be probable invasive aspergillosis. So mostly we are diagnosing as probable as invasive aspergillosis. Treatment of choice is voriconazole. Isavuconazole lipid formulations of liposomal ampho-B can be used. These are alternatives, but the problem is liver transplant people don't like LFTs to be deranged, and renal transplant surgeons don't want kidneys to be deranged. So liposomal has got very high incidence of AKI, so we need to balance. In liver insufficiency, it's recommended to use liposomal amphotericin B. POSA currently not available in Pakistan, but it can be used in refractory cases. Echinocandins again as a salvage, but we do remember that echinocandins do not go into CSF, urine, and eye. So in these infections, you don't use echinocandins. There was a debate, worry or ampho, which should be used. Actually, that has been resolved almost 2 decades back. That voriconazole, when used in a very large trial published in NEGM in 2002, there was a marked difference between voriconazole and amphotericin B. And I think 60% of these amphotericin B patients were on liposomal, which presumed to be better. There was successful outcome with actually markedly difference between vori. So the drug of choice for aspergillosis is voriconazole once we are using it. There was also much debate about whether we should do therapeutic drug monitoring of voriconazole. So this is data from non-transplant in which almost 80% of these patients in the middle low, they have actually, when you are using a standard dose of voriconazole, you do not need monitoring. But actually that's not true for in patients what we are encountering, because there are severe drug-drug interactions with what we are using as a immunosuppression. So roughly there is a rule of thumb, there should be more close monitoring of immunosuppression levels, particularly cyclosporin and tacrolimus. For cyclosporin, it's recommended that you can reduce dose by half when you are using cyclosporin as immunosuppression. And if you're using TAC, you can reduce the dose to 30% what you are using, and then more close monitoring of levels of both actually, voriconazole and tacrolimus if you are using. For sirolimus, it's usually recommended not to use it actually. It's better to avoid if you're using sirolimus along with voriconazole. Because of this drug interaction, there are so many people who use amphotericin because there's less drug-drug interaction, they are comfortable using. And in Pakistan currently, we don't have IV formulations available with voriconazole. So we end up starting M4 to be stabilize the patient, and then actually switch to voriconazole. About risk factors for mortality, hepatic insufficiency, malnutrition, and CNS disease have been increased risk of mortality, along with use of amphotericin B. So actually, guidelines have seen when you are using M4 as a treatment for invasive aspergillosis, there is more risk of dying with odds ratio of 4.4. So ideally, we should avoid M4 as an initial regime when we are suspecting invasive aspergillosis. So take home is that actually we need surveillance of fungal infections from our own world. What are our common Candida species? What is our true incidence of aspergillosis in our setup, so that we can know about real magnitude of problem. There should be high level of suspicion, because culture is not going to always helpful. Even not for Candida, not for Aspergillus. For PJP, we do have very good markers, but rest of two you need to have very good high suspicion of that. Antifungals have drug-drug interaction with immunosuppression. This means there is more close monitoring in these patients, and mortality is high for Candidemia and for actually Aspergillus both. In fact, PJP also has mortality of around 25 to 30%. Thank you. Any question?
Thank you, Dr. Sunil. So our last speaker is Dr. Furqana Akhtar. She is consultant infectious diseases in PKLI. Her diagnostic techniques have been an inspiration for many. Welcome, Dr. Furqana.
Thank you, Varda, and thank you, Dr. Adil, for inviting me. So basically, I'll be discussing about infections in transplant, and my topic is zebras in transplant. So it's hard to find zebras. So, and as we move forward, infections in transplants are difficult to treat, and that is because of many reasons. As like patients are immunocompromised, they do not usually manifest classic signs and symptoms of the diseases. Diagnostics are usually not always available. Whenever patient present, they usually present at advanced age with disseminated infections, and treatment is challenging because there is drug-drug interactions, there are increased drug toxicities, and there is suboptimal response most of the time. So infections in solid organ transplants or in any transplant are challenging. So let's begin our first case. Next slide, please. Okay, sorry. So, yeah, it's not moving. Okay. So our objectives are basically we'll be discussing two cases and their perspective and impact on and treatment options. So as we have discussed, so the case one is 47 years old male. He had history of end-stage renal disease. He remained on dialysis for 3.5 years, and then he received live related renal transplant in October 2020. Donor was wife, and she was CMV-D positive, R positive. And pre-transplant quantiferon TB Gold was positive. Post-transplant, he was offered universal isoniazid preventive therapy for 1 year. And other prophylaxis include Velgen cyclovir and Septron for PCP and others. This is 2 years post-transplant, and he presented with cough with scanty mucoid sputum, progressive worsening shortness of breath, and intermittent fevers. This was his X-ray. So there was some right-sided effusions. CP angles were not very acute, and there was some consolidation on the right side as well. So we went for CT, and these were few sections of CT. So you can see in the second image in the left upper lobe, there are some tree-in-bird nodularities and small nodules. And on the right side, there is small cavitatory nodule in the posterior segment. And the other section, so the ground glass appearance and tree-in-bird nodularity is more marked. Plus, there is a small mass with traction bronchiectasis and consolidation. So So we went for sputum cultures. It showed ESBL Klebsiella pneumoniae, which was quinolone sensitive, and it was sensitive to some injectable beta lactams, but there was no oral option except ciprofloxacin, which we offered. So we started the patient on ciprofloxacin 500 mg BID for 2 weeks. Then after 2 weeks, fever was settled, cough persisted, but it was now dry cough. There was no change in shortness of breath. Fatigue and asthenia continue, and plus now he's developing some graft dysfunction. His creatinine, which was normal earlier, is creeping up slowly. So we repeated HRCT after 4 weeks. So this was 4 weeks post-treatment HRCT. So most of the Greenberg nodularities and nodule which were there in the left upper lobes were resolved, but the right upper lobe nodule and the consolidation and bronchiectasis persist. But as the patient was clinically a bit improved, there were traction bronchiectasis they thought to be from like previous infections, because he had history of probably subclinical TB. So for which quantiferon was positive, so latent TB treatment was offered. So this was just observed, and we repeated another scan 4 weeks later. So you can see the left lower lobe mass nodule, which was initially small in size, now has increased significantly, and the consolidation on the right base is also there. So BL was done, and gram stain and GPC was positive for GPCs in GNR. AFB smear was positive, but TB gene expert was negative. And bacterial cultures, there were polymicrobial growth. There was Pseudomonas aeruginosa, Klebsiella pneumoniae, which was the same sensitivity as we discussed earlier. And there was another bug, which was E. coli. So as AFB smear was positive, so the teaching point here is if AFB smear is positive, then AFB MTB gene expert should be positive. So in a smear positive TB gene expert is almost always positive. But that was not the case with our patient. Our patient was AFB smear positive, TB gene expert negative, but that was not TB. Then what it is? It was MOT. We followed the culture, and 1 week later, TB cultures were reported as growth of rapidly growing Mycobacterium tuberculosis, or MOT, Mycobacterium tuberculosis other than TB, which was sensitive to amikacin, azithromycin, clarithromycin, and linazolid. It had intermediate susceptibility to imipenem and cefoxitin, and resistant to quinolone. So in treatment and diagnosis of MOT is challenging. Mostly in Pakistan, whenever a BL is done, all diagnostics were usually not sent. Sometimes they send AFB, sometimes they just send gene expert, no TB cultures are sent. Most of the time TB cultures are lacking. So in those patients, if we haven't sent all the things, AFB smear plus TB gene expert and cultures, we may miss patients. So only if you have done TB gene expert only and it's negative, then it does not rule out MOT. So NTM or MOT are basically ubiquitous in distribution. They are present almost in all environmental conditions, aquifers, shower heads, in water bodies, and they are present in almost all environmental conditions. They are somewhat resistant to treatment, and their actual incidence in solid organ transplant is not very well known. There are few studies which quotes it is 0.2 to 0.38% in kidney transplant and less than 0.02% in liver transplant. Timing after transplant is not very much defined, but it's mostly roughly 2 to 24 months. And the diagnostic and treatment challenges are there. First of all, we have discussed the diagnostic challenges, but the treatment challenges is also there, because most of the time we always have shortage of medication supply chains. Most of the treatment which are required are not there. TB, if they are divided into the rapid growers and the late growers. Late growers, NTMs usually require ATT plus clarithromycins. And when we talk about standalone medications of rifampicin, ethambutol, they are not available. So we have to give it with isoniazid, or if the patient developed drug-induced liver injury, then maybe we don't have anything to treat the patients. And when it's RGM, then mostly the speciation is not done. So speciation is important because Mycobacterium abscessus, which is the rapid grower, it is then further divided into 3 or 4 subclasses: Miscellaneous, Boleti, and Mycobacterium abscessus subspecies. So Miscellaneous have high susceptibility to macrolides. So if we haven't done speciation, we don't know whether what really is the susceptibility. And the drugs which are usually available for treatment, like imipenem and cefoxitin, if they are not available in a patient who is having kidney transplant, I cannot offer him amikacin or aminoglycoside because of the graft dysfunction, then practically I won't be having anything effective medication to treat the patient. So the MORT classification is basically, in the past we used to classify it on the basis of the appearance in the photochromogens, cotochromogens, and non-chromogens, and the rapid and late growers. Rapid growers, basically the Mycobacterium abscessus is the only one NTM which causes pulmonary infections. The other two usually less frequently cause pulmonary infection, and mostly they are involved in surgical site infections, skin infections, cosmetic procedures, and the prosthesis infection. So as we have discussed, it is present almost everywhere in the environment. The transmission is usually human to human, and it has got thick lipid-rich membrane, and most of the time it may be resistant to antibiotics and difficult to eradicate. And it requires spatial culture media for growth, and most of the time which may not be available in the routine labs, and many a time samples are not sent. So the pulmonary non-tuberculous mycobacteria we have discussed. The slow growing include MAC, which include Mycobacterium avium and Chimera, and Kansasai and Xenopi. Rapid growers are basically these three: Miscellaneous, abscesses, and Boleti. Then the risk factor basically depends upon if the patient is having any underlying structural abnormality. Patients living with cystic fibrosis, bronchiectasis, or other patients who have structural lung diseases, they are more prone to have NTM pulmonary infections. When it comes to immunocompromised status or solid organ transplant, patients who had admission in the last 90 days who had received antifungals, and those patients who were of older age at the time of transplant, they are usually the ones who had NTM infections, and gardening, hot tub, baths, and soil. Basically, these are the things. Mycobacterium abscessus has recently reported to have human-to-human transmissions. Before that, it was not recommended. It was not reported in the cases of NTM, but recently there is data pooling up with Mycobacterium abscessus causing human-to-human transmissions. And immunosuppressions, patients who were on steroids, who received immune modulators, and who had graft rejections or treatment for with ATGs and bacillizumab, they are basically the patients who will have NTM. So the IDSA 2020 IDSA guidelines, there is a criteria for diagnosis. So the criteria include if there is clinical or radiological findings, plus other diagnoses are ruled out, plus there is microbiological evidence of the disease, or someone has done a TBLB, transbronchial lung biopsy, or the open lung biopsy, and there is histopathological diagnosis. So for sputum, for all those patients who are producing sputum, you need to have 2 positive cultures. So, but for BL, only 1 positive culture will be sufficient in association with appropriate clinical presentation and supporting radiological findings. So the treatment is challenging for the reasons we have just discussed. So basically the type of transplant, because basically NTM most commonly involves the lung transplants and followed by the lung and lung and heart transplants. It is less common in kidney and liver transplant. And the severity of infection, basically it is divided into two types: fibrocavitary diseases and the fibronodular diseases and the cavitary diseases. So for cavitary diseases, you need to have 4 effective drugs, and for fibronodular diseases you can go for 3 drugs. And fibronodular lesions ke liye you can give drugs which are three times a week, like amikacin 3 times a week or other drugs 3 times a week. But for cavitary disease you need to give the patients daily regimen. Drug interactions we'll just discuss. There is toxicity of like amikacin, tigecycline, all the drugs. They have their own side effects, plus there are drug-to-drug interactions. And species identification is important because if it is Mycobacterium miscellaneous, then it is basically does not have B genes, and it would be macrolide susceptible, which is the cornerstone of treatment of NTMs. So the treatment according to ATS IDSA guidelines, rapidly grower, first line ATT has no impact on it. Like for late growers or slow growers, we can utilize ATT with clarithromycin, but for rapid growers, you cannot use it. So you should give a backbone of macrolide, which is azithromycin or clarithromycin. So azithromycin is usually better tolerated. It has got less side effects, and patient tolerance is usually good, and you can got good results. But even if it is not susceptible, the guideline says you should include it into the regimen because it will also act as the immune modulator, but you will not count it as an active drug. So if it is resistant or intermediate resistant to macrolides, you will need 3 drugs apart from macrolide, though you will include it, but you won't count it as an active drug. So you need 3 other drugs to be the part of the regimen. The other second line agents include linazolid, tigecycline, clofazimine. So clofazimine is usually not available, but sometimes we can get it through the leprosy center and sometimes through the MDR clinic, MDR TB clinics. So our patient got it from MDR clinics from Islamabad. And the duration is basically tricky. So you do monthly smear, and when the smear becomes negative, then after smear conversion, you treat it for 12 months. But abscesses is difficult. It's difficult to achieve sputum conversion in Mycobacterium abscesses, even in other mycobacteria as well, but more so in cases of abscesses. So the drug-drug interactions, Dr. Sunil has made it easier for me because it had been discussed. So azithromycin is a weak inhibitor, so should be preferred. It possibly increase cyclosporin and tacrolimus levels and does not have any interaction with sirolimus, so that should be preferred whenever you can. Clarithromycin does have significant interactions, and it significantly increases the tacrolimus and cyclosporins levels. Aminoglycoside increases the risk of nephrotoxicity when combined with tacrolimus and others, so should be avoided. But if you don't have any effective drug, then you can continue with monitoring of drug levels and monitoring of creatinine. And fluoroquinolones, usually they are safe. There are no interactions. There are some possible interactions, but no well-defined levels increase with tacrolimus or cyclosporin or tacrolimus. So moving on to second patient. So it would be easier for you because Dr. Sunil has just discussed it. So it's a 42 years old male. He had DCLD, secondary to HCV, and he had history of treated pulmonary TB in childhood. He had HCV treatment with direct acting antivirals. SVRs were achieved. CTB C12 MELD 42, so he was a high melder with acute acute and chronic liver failure with CLIF score of 46. He had live donor related liver transplant in December 2022. Donor was sister. She was CMVD positive, R positive, EBVD positive, R positive, and it was O to A donation. So operative course was uneventful, 10 hours, 40-minute duration. Blood loss was 1800 ml. Uneventful course. Perioperative prophylaxis was given with piperacillin tazobactam. On the third post-op day, patient was failure to wean from ventilator with increasing FiO2 requirement, hypoxemia, increasing pressure requirement, worsening infiltrate on chest X-ray. So these were the chest X-ray. So you can see there is on the left there is evolving infiltrate, and we since the patient was intubated, we took the tracheal aspirate and sent it for pneumonia panel or biofire, which was this. So it had Klebsiella pneumoniae, E. coli, which was 10⁻⁷ copies positive. In the resistant genes, it was CTX-M, NDM, and VIM positive. So basically, it was CRE, means carbapenem resistant Enterobacteriaceae. So it was a resistant bug, not likely susceptible to meropenem. So, and this was the there was no atypical bacteria which was positive, and all the viruses were negative. So we started the patient on high dose meropenem with colistin loading, and then the maintenance dose. Fever plus WBCs improved a bit. FiO2 started coming down, but he was not we were not able to wean him from ventilator, and we're literally struggling. So on day 8 there was increasing FiO2 and PEEP. There was no pressors, and there was worsening infiltrate, which was day 8 of LDLT on the right and day 9 of LDLT on the left. So you can say they are evolving infiltrate bilaterally, but this was the CT. So you can see there is bilateral extensive ground glass haze, mostly central in location with peripheral sparing, and that's it. So BDG and galactomannan was sent, tracheal aspirate for PGP was sent, Septron was added, and steroid was increased because the other close differential was pneumonitis due to allergic BOOP or allergic bronchopulmonary. So BDG came out 430 and galactomannan was negative, LDH 540. So in Dr. Sunil has just told you what is the timeline of PCP. So it's usually 1 month to 6 months. But in this patient, after starting FiO2, after starting Septron, FiO2 started improving. Patient was off pressors, afebrile, and PJP PCR was positive. So this was really tricky one because it's hardly seen first week post-transplant PJP positive. So we started the patient, we made the diagnosis of PJP pneumonitis, and it is already been discussed with Dr. Sunil that it's the fungus, it is ubiquitous, everywhere present. Previously, it was categorized as a protozoan, but in the recent year, it is categorized as a fungus because of the fungal RNA, and it is included in the group Ascomycetes. And it is a bit different. So any of you must be thinking why we didn't use antifungals in this case, because if it's a fungus, so why not Septron? Why Septron? Why not amphotericin B or other things? Because all amphotericin B, fluconazoles, all azoles, and nilstat, basically the mechanism of action is ergosterol synthesis. So in PJP, there is no ergosterol. So these antifungals are ineffective. There is 1,3-BDG in the wall, and now data is coming up with caspofungin used in the treatment of PCP. So we have, I think, in the interest of time, as we are already lagging behind the schedule, I would just skip it. And because it is just discussed, so it does have some extrapulmonary manifestations, especially in patients who have given pentamidine for prophylaxis, because pentamidine prophylaxes the lung, but it can have disseminated infection at other places like central nervous system, GIT, bone marrow, lymphadenopathy, eyes, and thyroid, but it's not very much like it's not very high in numbers. So the sputum smear has poor yield if it is done just a single sputum smear. You combine it with the fluorescent monoclonal antibody staging, which increases the sensitivity. BL has 70 to 80% estimated yield, and it has increased significantly when you combine it with TBLB. TBLB is basically transbronchial lung biopsy. So if we if we combine BL with TBLB, the yield is increased. PCR is very good in diagnosis, but it can pick false positive cases. You cannot really differentiate between colonizations versus true pathogens. So in that case, if you combine it with BDG and in appropriate clinical scenario, then you may make the diagnosis. So we started the patient on Septron, steroids were used, and on day 3 or 4, as patient was not improving. So though the treatment failure is usually at day 7, but our patients were immunocompromised. At day 4, he was really not improving. We added clindamycin. We didn't have primaquine. We added clindamycin to the Saptron, and we completed 3 weeks of treatment, and this was the CT post-treatment. So almost complete recovery, at least radiologically. So this was the case. Take home messages: you should always individualize the care. You should always, it's not one size fits all thing. You should always individualize patient, try to make diagnosis, and take into consideration the common presentations of uncommon infection, but the uncommon presentation of common infections is most important. And you should always have high index of suspicion. Questions? So no questions. Thank you.
Thank you all for being here. This conference was an excellent opportunity for us to learn. Now I will request Dr. Adil Manzoor to come for shield distribution.
Thank you. I'm very pleased and delighted by all of you who came and attended the conference and also the online. And inshallah, every year we'll be doing, and next year my plan, I was discussing with Dr. Rostang and Dr. Naveed also, that next day, inshallah, 2 days, and these 3 gem of the faculty of SIUT will be there, but inshallah 1-2 more from the SIUT and from other parts of Pakistan also, and probably in the same year. Now I will start distributing the shields for the speakers. Varda, Dr. Khawar Abbas.
Dr. Muhammad Mubarak. Dr. Sunil. Dr. Mudassir. Dr. Ahad Qayyum. Dr. Mahjabeen. Dr. Hisham Ahmed. Dr. Furqana. So Dr. Khabar ko bula leta aapko देंगे आपके लिए. I would like to request Dr. Khabar to come and give a shield for Dr. Adil Mansur. So Dr. Naveed Server.
We give both the shields of Rostang and Dr. Nali to Dr.
Dr. Lionel Rostang.
So we will now close the conference. Thank you so much.